Good evening, everyone. Thanks for being here. It is my pleasure to introduce Dr. Sandhya Gurubasapa. She is a diabetologist based in Hyderabad. Currently, she is a consultant diabetologist at Nanomedics Hospital, Hyderabad. She did her MBBS in 1992, diploma in diabetology in 2008, and master's in diabetology in 2011. Besides, she has done various other certifications related to diabetes management. Previously, she has held positions at various hospitals in Hyderabad and Saudi Arabia. Her experience covers general practice, emergency medicine, and specialization in diabetes management. Dr. Sandhya is a life member of many diabetes organizations in India, and besides, she is a very good speaker. So, over to you, Dr. Sandhya.
Thank you very much for the kind introduction and good evening, everyone. And yes, the Ramadan month is going on, and of course, we have to give little bit more information or bit of a more counseling to the all of our diabetic patients who are really doing the fasting. So I'll be mainly focusing on the Ramadan and diabetic management in India. So you see the diabetes in India, the incidence is increasing day by day, and India has become the second largest in the world, and the prevalence is almost 9.6% among the adult who are age 20 and above. And if you really see, everyone in the family are diabetic, and as per the data, it is 1 in 11 adults are living with the diabetes. So it's apart from the diabetes, there are many pre-diabetic population in India. If you really see, almost 50% of the adult living populations are not diagnosed, and of course they are if we do the screening program, and they turned out to be a pre-diabetic. A new study published in the Lancet, which reveals almost 101 million people in India, consisting of 11.4% of the population, have diabetes. So it is our responsibility to screen each and every individual and screen for the pre-diabetes, and you have to give a good counseling for these patients. It happens only with the teamwork. Actually, all the specialities has to be involved in this with respect to the screening program and detecting the diabetes and catching hold of the all the diabetic who are pre-diabetic, who are increasing the incidence of like complications and other things. The state with the highest diabetes prevalence are Goa and Pondicherry and Kerala. It's of almost of 25%. The study of the anticipates a substantial increase in the diabetic cases in states like UP, Madhya Pradesh, Bihar, and Arunachal Pradesh, where prevalence rate are slightly on the lower side. So we should go into the pathophysiology of the fasting in diabetes. So most of our the patients who do fasting during the time of Ramadan, they totally cut down on the carbohydrate on certain time of the period, like from morning to the evening period. That means to say that the effect on the pancreas is shows that insulin secretion is completely impaired, and secondary to the insulin resistance in the type 2 diabetes, and chronically glucagon reduction in the glucagon will also will happen. No insulin secretion and glucagon secretion impaired in the type 1 diabetes, which leads to stimulation of the pancreatic gluconeogenesis and glycogenolysis, which has a greater impact on the ketosis and keto, especially in the type 2 diabetes, and ketoacidosis with the type 1 diabetes. If you see the blood sugar pattern during the Ramadan, there is a lot of variations happening. If you compare to the normal period when there is a peak, not normal patients who doesn't do the fasting, there will be perfect raise and ups and downs in the sugar levels. Whereas when there is any calorie restriction has been made for any patients, 100% there won't be any peaks are not observed at all. And at the time of Ramadan, there will be a completely peakless in the from morning till evening, and there will be lot of variations in the fluctuations in the evening, that is after iftar period. We need to, who is required to do the fasting and who are not supposed to do the fasting, that is risk stratification in diabetic patients. So if you see low risk patients, like patient who can probably can do the fasting, or we have to do the complete medical evaluation, and medication adjustment has to be done for each and every patient, and strict monitoring has to be done. So if you see a patients who are between the 30 to 50 years or 60 years, and who are having a very good control over the sugars, and we can still we can advise them to go for a fasting with the change in the medication pattern. Like patients who are on using sulfonylurea or insulin in the daytime, we can change it in the evening time and change the other medication like DPP-4 inhibitors or the SGLT2 inhibitors in the daytime, so that we can get, I mean, patient will not go in for the hypoglycemia or the side effects. So the strict regimen has to be followed. The moderate risk are patients who still wants to do the fasting. They should be advised for a proper diet counseling, and also the SMBG has to be implemented. Means we have to recommend for them to do the self glucose monitoring system for at least 3 to 4 times a day. If at all they see that the sugar levels are going low, then they have to advise to stop the fasting, and we have to advise them to have something. High risk patients are the one who are having a kidney problems, or patients undergoing having a insulin therapy, multiple doses of the insulin, and of course there are elderly individuals, and of course the pregnant ladies who are diabetic. These are the subset of the patients who absolutely contraindicated for the fasting. So type, and it also depends on the type of duration of the diabetes, and what all medications. If the patients are having a polypharmacy, like multiple medications for hypertension as well as the diabetes they are taking, probably these patients are the one they require a, strict control and a regular frequent monitoring. And these patients has to be counseled before they start before the month of the Ramadan, at least 15 to 20 days before the month of Ramadan. Level of glycemic control is very important. Yes, of course we have to advise them to go for a pre Ramadan checkup, and during the time of Ramadan also we should advise them to come for the follow up. Risk of occurrence of hypoglycemia is very important, because patients who are on hypoglycemia or on sulfonylurea or insulin, they have to be strictly warned. Diabetic management, self management is really important for these patients. The complications and comorbidities for the any type 1 or type 2 diabetic patients are to be warned strictly not to go for any fasting. Renal impaired patients also very much important. So coming to the diabetes assessment care plan actually. So risk quantification is important. Advice about the SMBGs, when to break the fast is very important, and of course the exercise pattern has to be changed. And coming to the Ramadan fasting, and the time is very important, because this is happens to be a peak summer actually, and whenever they are water or fluid fluid is reduced, absolutely they'll land up with the dehydration and many more sunstroke and all. It also depends on what type of work the patients are doing. Depending on the work pattern, they may have to advise whether they can fast, they can ask for the fasting or not. The detailed history and very important, and patient ability to self manage the diabetes is again important thing to be counseled, and of course the type of work they are doing. If the patients are working at the office or in the IT sector, and these patients can be advised to go for a fasting, but certain patients who are working in the outdoor, especially in the severe heat, they require a fluid replacement actually very frequently, and these patients are the very difficult to manage it. That's the reason probably we may ask them not to fast. Coming to the 5 hours of Ramadan care, yes, respect. Of course, we have to respect the religious issue, but of course, we can even tell them to go for a prayer, but without any fasting also. This stratification has to be done. This is the essential backbone of the pre-Ramadan counseling. So before Ramadan, we have to call all our Muslim patients for a counseling, real counseling, and a revision of the therapy. Suppose the patient are using sulfonylurea or insulin, probably we can stop the sulfonylurea and insulin in the morning, or probably change the insulin therapy to the longer acting or ultra long acting insulin rather than the premixed insulin in the daytime, and they get a better control over that. And regular follow-up is really mandatory, and healthcare professional has to be involved in this. And we have to explain the safety and healthy fasting experiences also. And we need to tell them, especially for having a good quality food rather than a junk food or high calorie food. And most of our patients, they come up with high sugars, and of course increased weight gain after the Ramadan. So strict counseling has to be done for each individual. The therapeutic strategies for the diabetic management is early initiation of combination therapy is very important. Novel medication therapy like DPP4 inhibitors, SGLT2 inhibitors, and GLP1 receptor agonists is the better choice. So if we can change from sulfonylurea to these combinations, probably we'll get a better results without causing any hypoglycemia and without increasing the sugar levels. Of course, even when we prescribe the molecule in the morning time, SGLT2 and DPP4 combination, probably if patients require a higher dose, then in the evening iftar time, we can advise them to go for a sulfonylurea and even a premixed insulin as well. The smart combination of SGLT2 inhibitors and DPP4 inhibitors, yes, it's a wonderful combination because the SGLT2 inhibitors doesn't cause any hypoglycemia. The only measures has to be taken is the increased intake of the water and possibility of infections, urinary tract infections. So by giving a good counseling of water intake at least before the starting of the fasting, they have to drink plenty of water. And if there are any chances of infections or any other issues, probably we have to discontinue these SGLT2 inhibitors also. The safest molecule can be used are DPP4 inhibitors along with the metformin therapy, which is really weight neutral, and yes, they don't have any, I mean, there is no much incidence of hypoglycemia. Dapagliflozin for diabetic management during Ramadan. Yes, this is the molecule which can be used for all of our patients, which are effective and safe and well tolerated with the advantage of the reduced hypoglycemic events. Even the sitagliptin for diabetic management in Ramadan, yes, the systematic review on efficacy and safety of the current hypoglycemic agents in patients with diabetic during the Ramadan fasting also it has been established. And the sitagliptin, it's a very well trusted molecule, almost like 2 decades, which is associated with 50% less hypoglycemic events and the symptomatic hypoglycemia. Thank you for your patience.
Thank you, Dr. Sandhya, for an excellent review on diabetes and Ramadan. The practices we have to follow, that we have to get first a pre-Ramadan checkup for risk certification, and then you also nicely discussed how we stratify these low risk, moderate risk, and severe risk category, and accordingly how do we guide them, especially when it comes to dosage adjustment. So a very nice view. I'm sure there will be many questions. I will start with the first question. What are the primary hurdles encountered by individuals with diabetes in India during Ramadan, and how can general practitioners aid in surmounting these obstacles? You have been to Saudi Arabia. Obviously, they also practice Ramadan, but the population and the practices are different. So, what do you think are the primary hurdles here in India during Ramadan?
The elderly individuals are very important. These are the patients, they are very rich, religious person. They want to continue the fasting during Ramadan. There is a big challenge with the elderly individual, one subset of patients, and other one is you patients who are on multiple therapies like sulfonylurea and insulin, and who also have comorbidities like renal parameters or deranged, and yeah, they are using multiple medications for cardiac problems. All these patients are the major challenge for us. And for these patients, probably like patients who are above 70 and all, I insist them not to go for the fasting. But if they still insist, I'll slightly change the medication pattern. Like I'll change the insulin to longer, ultra long acting insulin in the night time, and the sulfonylureas are discontinued, and use the DPP-4 inhibitors along with the metformin therapy. This is what, and even the anti-hypertension medications also slightly modification has been maybe done.
Right, thank you. I hope you are connected because there was some glitch in between. The next question is what are the possible advantages and drawbacks of individuals with type 2 diabetes during Ramadan? And how should doctors or healthcare providers educate patients about these aspects? Possible advantages and drawbacks of Ramadan fasting for diabetes patients.
Advantages, yes, there will be some advantages, like they can streamline their habits, they can cut down on the calories, and having many times binging on the food and all can be reduced in fact. But many times it happens that they'll end up in overeating in the evening. Actually, that is the major disadvantage, and that is the point where we may have to explain them and counsel them not to go for a high calorie food during that time. They can have a salads and fruits and all these things, and try to reduce the total intake of the carbo.
So one more question we have is which pivotal signs and symptoms of hypoglycemia and hyperglycemia should individuals with type 2 diabetes fasting during Ramadan be vigilant for, and what steps should they take if these manifested? So
And
essentially, symptoms and signs of hypoglycemia and hyperglycemia on which patient should act. Maybe he has to break the fast,
yeah, the
maybe do
major
something more.
major problem of any diabetic management or diabetic patients who are on certain medications, they'll end up in hypoglycemia. The hypoglycemia is the one thing which has to be focused very much, because uh, patient should be educated properly on the self glucose monitoring system. And morning time avoidance, we have to avoid all the sulfonylureas and insulins. So hypoglycemia, they land up with severe sweating and palpitation, and any unusual symptoms, immediately advise them to go for a self monitoring of the blood sugar. And if there are any sugar levels are very low, they have to be advised on usage of what items to be taken before they reach the hospital. That is what has to be explained. Coming to the hyperglycemia, yeah, we do get hyperglycemia also even beyond 500, 600. But the problem comes when the patient will go in for severe dehydration. That is the time, especially type 1 diabetic, when they go for ketoacidosis. Many times they go for fainting episodes and severe dehydration. For these patients, I generally advise not to go for any miss the dose of the insulin, and not to go for any fasting. Important.
Another important question is how should the general practitioner counsel individuals with type 2 diabetes regarding the timing and content of meals during non-fasting periods in Ramadan to mitigate fluctuations in blood sugars? Essentially, there are three meals. One is the sahri or sahur, which they take before dawn. or before starting the fast. And the other is the meal is the iftar snack, with which they break the fast. And then is the heavy meal, the iftar meal. So typically, it is not only fasting; so it is a month of fasting and feasting. So,
Feasting,
what are
yeah.
the guidelines for diabetic patients when they are feasting? What things they should consider to avoid fluctuations?
Well, Ramadan is the month of fasting and feasting, actually. Yeah, after working in several years in Saudi Arabia, I understood that lot of changes will happen with every individuals. They'll put on gain weight instead of losing weight, in fact.
Yes,
During the if I mean morning time, yeah, they can go for a lot of salads, fruits, and of course small quantity of carbohydrate. But the problem comes at the time of iftar, because they'll be eating a lot of sweets that has to be avoided. When they break the fast, yeah, absolutely, they'll go with one date and some fruits, and that is a minimum they will be doing, because after that they'll be going for prayers. But the problem comes is the iftar, actually. Iftar and the all night, actually. Most of them are awake till midnight, 2 o'clock or so. So that is what that has to be changed, in fact. They have to reduce the intake of the sweets, and they can go for a good protein content and a lot of fiber and lot of vegetable, rather than going in for the high carbohydrate diet, actually. Yeah. And especially during the Eid or some partying and all, they tend to eat a lot of high calorie, like outside hotel biryanis and whatever this content, which is very high calorie thing, actually, which is not advisable for these patients. That is the reason during those days we will be giving extra dose of insulin. If the patients are on insulin, yeah, short units, I mean, ultra short acting insulin has can be advised for these patients.
right. Thank you. Another issue is of monitoring. How do we monitor them? So, what methodologies should we employ to effectively monitor and trace blood glucose levels in these diabetes patients during Ramadan? And what should be the frequency of monitoring? Like typically, we do a 7 point profile in a non-diabetic. So, similarly, what are the different points of time we should do their sugar measurements, glucose measurements?
First of all, 10 to 15 days prior to the Ramadan, we'll ask the patients to come. We'll be giving a good counseling. And
Right.
once the Ramadan starts, there are a couple of subsets of the population where the patients are new onset diabetes or history of 1 or 2 years, who are only on DPP-4 inhibitors and metformin therapy. For these patients, I suggest them to go for once or twice in a week time. But patients who are using multiple combination of medication, of course, I advise them to take at least 3 or 4 readings per day. If there are any changes like hyper or hypoglycemia, then they have to immediately report to us. And if there is any chances of hypoglycemia, they have to quit the fasting. They have to take something orally. That is the instructions will be given for the patients. Coming to the elderly individuals still who insist on going for fasting, yes, I advise them to go for a regular self monitoring, or as a continuous glucose monitoring system can be advised for these patients.
Right. So they have to do a pre-sahur check, and then 2 hour after sahur, and then they have to do in the noon and pre-iftar and 2 hours post-iftar. And anytime if they have any symptoms such as of hyper or hypoglycemia. Right. Thank
7 point,
you.
yeah.
Another issue of Ramadan is the physical activity and the change in lifestyle, the sleep pattern. So, what are the endorsed lifestyle adjustments encompassing physical activity and stress management techniques for individuals with type 2 diabetes during Ramadan? And how can general practitioners aid in their implementation and adherence? Because activity goes low, and sleep also is disturbed, and many people get stressed. So, how do you deal with that stress? Some general guidelines you give to these patients? about lifestyle.
Yeah, stress. Yes, stress is one thing which has to be focused, and what I feel is the meditation or the prayers what they are doing 5 times daily that helps in relieving the stress actually. Coming to the exercise aspect, yes, during the time of fasting, it is bit difficult for us to tell them to go for an exercise. So only the time they get it is in the before the sohar. They can go for a little bit of exercise. That is little bit difficult for them to do it. And yeah, after dinner, if they get really time, because in India it is very I mean, I cannot say that here it is like work is very strict in the sense they have to work as a regular like other people. Unlike in Saudi Arabia, where they'll be working for only 4 hours or so, and they will be given extra holidays during these times. And for them, they can really adjust the timing. But in India, it is not possible. So I advise them just go for a just a minimum walk or a regular yoga that can be done at their convenient time, but that is like after having a very light evening after fasting. I mean, after breaking the fast, they can go for a minimum exercise. Later on, they can continue their dinner. That's what I tell them. But it is many of my patients they don't go for the exercise because of the timing inconvenience.
Right. So let us come to the oral diabetes drugs. Two popular types of drugs we use is gliptins, DPP4 inhibitors, or and SGLT2 inhibitors. So, what are the potential merits and demerits of integrating SGLT2 and DPP4 inhibitors for individuals with diabetes observing Ramadan fasts? So, do you see any merits and demerits if we integrate these two in the because they don't cause hypoglycemia compared to sulfonylurea, so we prefer them that way. But what things we have to be conscious merits demerits of SGLT2 and
Combination of the medication, yeah, combination of the medication SGLT2 inhibitors and DPP4 and along with the metformin is a wonderful combination. But however, during the time of summer, actually, the SGLT2 inhibitors they do causes the urinary tract infections because of reduced intake of water in the daytime. So during that time, it is little bit difficult for us to ask them to take in the morning. That is the reason we tell them shift the molecule to the evening. In fact, after iftar, if they can take the whole night, they can continue to have their water intake. I mean, good water intake. So the combination works very well. But however, the morning time dose will be if the patients who are on SGLT2 inhibitors, I will prefer to change it to the evening after iftar. And DPP4 inhibitors, I can continue in the daytime as well. And if at all they are using any sulfonylureas, probably I'll be cutting down on the dose of the sulfonylurea to the minimum.
right.
Yeah.
The
And
next question,
coming to the benefits of benefits. Yeah, you asked about the benefits. DPP4 inhibitors, a wonderful molecule with the no or minimum hypoglycemia and no weight gain actually. And SGLT2, wonderful molecule with respect to the glycemic control, and also has a special benefit in the reduction of the blood pressure of 3 to 4 millimeters of systolic blood pressure, and also weight loss is very much observed. But however, the only problem is with the UTI problem. That is a thing we'll be changing the molecule to the other half of the day so that they will be more comfortable.
right. The next question is actually you answered that question. That is about when do we initiate SGLT2 and these DP4 inhibitors? Should we initiate them during Ramadan or we should initiate before Ramadan? And also about the weight regulation. I think you have already answered it. That SGLT2 we should not introduce right in Ramadan. If you plan, then we should do in the pre-Ramadan
Yes.
counseling. We should introduce that. And SGLT2s because they can cause dehydration, they can cause diuresis. So in summers, when the days are long and hot, they may cause dehydration during the day. So we should use them in the evening. That you have said. DP4 inhibitors, there's not much problem. So you can use them the way you use them. You can use them after dinner also, iftar dinner, or you can use them after at the sahri also. Right. So one more question is what are the conceivable effects of combination of SGLT2 and DP4 inhibitors on weight regulation in individuals with diabetes during Ramadan? So what will the effect? You said that most of people do not change weight, though some people may gain weight, those who indulge too much of feasting, and some even lose weight, who are used to taking a lot of snacking during the non-Ramadan days, so they may lose weight because their snacking stops. So any word about this combination as far as weight management is concerned?
The combination works very well with respect to the reduction in the UTI problem. In fact, that's what I have observed. And coming to the weight loss, more than in Ramadan, we are more concerned about the glycemic control. Important because the weight loss will not be that much because the intake will be much on the higher side. So if we at least reduce the glucotoxicity by reducing the glycemic variability, at least we'll be doing some benefit for the patient. That's what is very important. That's what I believe in it.
Right, you are. The last question.
Here we are not
What are
really targeting on the weight loss, actually. Yeah,
Yes, that is right. We focus on glycemic management and reducing the variability rather than weight. Of course, we guide them, but then it's up to them. So the last question is, what are the recommended protocols for managing hypoglycemia and hyperglycemia in individuals with diabetes, utilizing both SGLT2 inhibitors and DP4 inhibitors during Ramadan? Because these are the drugs we commonly use, so people want to know everything about these two drugs and the combination. Generally, they do not cause hypoglycemia, but
sorry, repeat again the last.
generally these two drugs or group of drugs do not cause hypoglycemia. But if somebody is also on a sulfonylurea or on insulin, they may aggravate hypoglycemia. Similarly, hyperglycemia can happen if person eats more than what is prescribed for the person. So, what is the protocol generally for managing
Required.
hypoglycemia and hyperglycemia? It's actually coming to monitor and recognize the symptoms and treating it, and you have to break the fast. Actually, it's about that.
Absolutely. Yeah.
Okay, I think with that we
Managing hypoglycemia, yeah, I have already mentioned about it. I
right.
already mentioned about it. Yeah, if there is any incidence of the hypoglycemia, probably they have to fast at that moment. That is the reason we advise them to go for a multiple sugar SMBGs actually, so that they'll get to know. And if there are any symptoms of hypoglycemia, absolutely immediately the sugar check has to be done, and they have to break the fast at that moment. And coming to the SGLT2 inhibitors, there is always a chance of dehydration where they may get little panic during that time. Even at that time, also we advise them to go for a sugar check. And if still within normal limit, and if the patient is getting dehydrated because of the severe summer, if the patient is working outside and they're getting little panic, I advise them to stop the fasting, and they have to consume the water immediately so that they will we can yeah